I'm going to go ahead and get started. Would someone mind pulling that door for me real quick? Thank you, ma'am. Appreciate that. All right. The next session is Infertility 101, and we are very lucky to have Dr. Marsh here from the KU Med Center, and she will take it away. Please join me in welcoming Dr. Marsh.
Thank you so much for having me. I'm going to back it up a little bit. Dr. Braybeck did an excellent presentation on IVF, which is sort of the really high technology route for infertility. So I'm just going to back it up and just talk about infertility in general. Any questions that you have during the presentation, feel free to jump in. We'll have time for questions at the end too, but I try to cover a lot of different just general topics of things that you might be wondering. So just looking at what is infertility. So if you're less than 35, it's that you've been trying for at least a year to get pregnant on your own and it hasn't been working. If you're in a same-sex relationship or if you're using donor sperm, this definition is the same. It's still trying for a year. Once you get above 35, the timeline changes a little bit. So you have 6 months before we call it infertility. And then if you're above 40, we'll see ya. I mean, we know that the time is, crunching by that time, and so we're happy to see anyone after the age of 40. So in terms of the early infertility evaluation, about 15% of couples meet the standard for infertility. That's a lot. That means 85% of people don't have a problem getting pregnant, but 15% do, so you're not alone. Earlier workup before 12 months or 6 months or whatever the age-appropriate definition is for infertility may be warranted if you have some special conditions. If you have very irregular periods, you may need to see us sooner. If you have really bad endometriosis, that's another thing that can affect infertility or affect fertility. If your tubes are blocked or you have problems with your uterus, we want to see you sooner. Or if you feel like you may have a lower sperm count or some problem there, those are all reasons that we would see you before you met the 12-month criteria. So what is infertility? It's very complicated. It's not one size fits all. Every couple is different. We're looking for healthy sperm and eggs. Your tubes have to be open. The sperm has to reach the egg and fertilize the egg, and then that embryo has to implant in the uterus, and then it has to grow. So I'm always amazed that anyone ever gets pregnant. That's right. It just seems impossible. You see these shows where people are getting pregnant all the time. How does it ever work? Because it's so complicated. So this is a video, and I don't know if it's going to start here, but it kind of takes us through the process of, I don't know if it's going to go. Well, we may not ever see. Well, this is a video, and you guys probably can get on YouTube and find it yourself, but this is a journey from the perspective of the sperm and the egg. So it takes you through, if you YouTube it, you can find it. But it's a cool video. It's from the UK, and it shows you how long it takes for the sperm to get there, and how the cervix blocks a lot of the sperm, and just all the different barriers there are before you have that healthy baby. So it shows you just in detail how complicated things can be with getting from, I want to be pregnant to that healthy baby. So what causes infertility? First of all, no one is to blame. I mean, a lot of times there's contributing factors on both sides. Even if it looks like that it's more one-sided than another, it takes two. So this is a team approach, and we're here to support couples. So we find in about a third of the cases that there are issues with the sperm. And there's about a third of the time where it looks like it's more female-sided, and then a third of the time it's both. So really, like I said, it's a team approach, and even if it seems like, I'm not ovulating, I know that's the issue, come and see us, because sometimes it's more than you think, and we're happy to help and support as a couple. So how do we diagnose infertility? First of all, you heard the time criteria, so it is sometimes just based on the amount of time trying. But we evaluate, if we can, both partners at the same time. We want to look and talk to you and talk to what you've been through, possibly do an exam or an ultrasound. Talk to you just about you're trying to get pregnant, being healthy, taking prenatal vitamins, getting to a healthy weight. All those things that you can do on your own that's going to set you up for a healthy baby. We talk about genetic screening so that we can see ahead of time if you're a carrier for anything like cystic fibrosis or any other kinds of genetic disorders. And then we also will do diagnostic testing. So then we'll really try to pinpoint what's going on. Is it a problem with the uterus, a problem with the egg, a problem with the sperm? You know, we'll really try to dive in there and see what the problem is. So in our diagnostic evaluation, you'll check for ovulatory function. What that means is, are you releasing an egg each month? Are your periods regular? That's what we want to know. We have tests that we can do to look for that. You may be doing tests at home, ovulation prediction kits, where you pee on a stick and see if you're having that smiley face every month. Basal body temperature, all of those things are things that we use as useful tools that come from you. We also check to see if you have a good number of eggs. We heard from the last presentation that number of eggs does go down as you get older. We want to see where you're at. We know that as each day goes by, it does get a little bit lower. But we want to see where you're at on that scale and how aggressive we need to be. Wherever you're at on the scale, we'll help you. We want to check for your uterus and your fallopian tubes. Are they blocked? Did we not know that? If that's something that's going on, that's a game changer. So we want to check everything at once and make sure everything's okay. What common question I get is, do we need to do laparoscopy? And that's really only if you have symptoms or if there's something suspicious on your ultrasound. So not everyone gets a laparoscopy. That's kind of a thing of the past. And we also have to check sperm. So we do a semen analysis and make sure everything's looking good that way. And we have a good team of people, including a reproductive urologist at KU, that can help if there's any problem on that side as well. So we really take this as a team approach. So we talked a little bit about this. When you're talking to me, when I talk to you about are you releasing that good egg each month, there's a lot of things that you can help us with. Are you having regular periods? Are you doing those basal body temperatures? Have you done those kits and they're always positive or always negative? All of these things are frustrating, but things that we can help with. Some of your OBs may be checking up progesterone at the end of your cycle to see if you're ovulating. These are all good things for us to see. Is that egg being released? And then when you get to a lot of the reproductive clinics, we'll do ultrasounds to check and see, is an egg growing? Is an egg going to be released? So that's another way to take it to the next level to make sure everything's going okay. In terms of checking your eggs, so some types of ovarian reserve testing to see where are your eggs on that spectrum. Do you have a lot of eggs for your age? Is it a little fewer than we'd expect? If you're over 35 or have risk factors for a low number of eggs, you may be getting some of these tests. One of them is called an anti-Müllerian hormone, or AMH. You guys may have heard of this. Each little tiny egg that you have at the beginning of your cycle releases AMH. So we want this number to be high. And your doctor will talk to you about what that means. That helps us predict what you need in terms of fertility treatment from us. We may catch you in the beginning of your cycle, cycle day 3, while you're still bleeding on your period, and check your FSH. That's follicle stimulating hormone, and your estrogen, and see how your brain is communicating with the ovaries and see how that's working to see how your ovaries are functioning. And then finally, we may do an ultrasound and just count all those number of eggs. You guys may have been through that where we take a count and tell you this is how many eggs we think have a pool for growing an egg this cycle. That also helps us understand how your body is in terms of that spectrum. When we check your uterus or fallopian tubes for abnormalities, the most common test is that third one, hysterosalpingogram, or HSG. That's a dye test where a radiologist will put dye into your uterus. And if you guys have had one, you know it's sometimes pretty painful. But it is the gold standard for checking to make sure those tubes are open and the baby has a good place to grow. Some of the other things that may be used are an MRI, or doing ultrasound, or a saline sonogram, or even having to do hysteroscopy with laparoscopy. All of those things check uterus and tubes, so your doctor may recommend any one of those. How is infertility treated? There are a lot of options. Like I said, this is not one size fits all. And you are a partner in this team for choosing infertility treatment. We can do drugs to boost ovulation or to boost sperm count, surgery to repair fallopian tubes or correct your uterus, or repairing varicoceles, which are like little dilated varicose veins on the scrotum, which could be causing problems with fertility. So there are a lot of treatments that don't involve IVF and don't involve IUIs and all those complicated things that we do offer. So now, what is an IUI and what's a TDI and what are all these acronyms that we use and throw around everywhere? It's very confusing, and believe me, even from clinic to clinic, it's very confusing what these things are. So IUI is an intrauterine insemination. So artificial insemination is sometimes what it's called. All that is you can see the picture there. That's where we wash the sperm, get the best swimmers, and we put them in a little tiny micro droplet, and then put them into your uterus. So they're very close to those eggs and have a better chance of fertilizing. So that's what an intrauterine insemination is. A TDI is called a therapeutic donor insemination. That's where we're using someone else's sperm besides your partner's. So if there's severe male factor or some other reason, if you're in a same-sex relationship, that's when we'll use the therapeutic donor insemination. And like I said, we wash the sperm ahead of time, so we only get those best swimmers. We talked about what IVF was. Dr. Braybeck did a great job, and that's in vitro fertilization. That's where the eggs, you can see in that top picture, there's an ultrasound placed in the vagina, and a needle goes through the vagina. This is all while you're asleep, so it sounds scary, but most people do not remember it. And a needle goes into the ovary, and those eggs are suctioned out. Then we mix the sperm with the eggs outside the body. That's a picture on the bottom there of the eggs trying to fertilize, which I think looks really cool. And then that fertilized egg, which is an embryo, is then put into your uterus. And that's basically IVF. But that accounts for less than 5% of all the fertility treatments. So even though IVF is what people talk about a lot, I think, too, and it is, it's a very big deal, it's not the majority of what we do. 95% of what we do are other things. So don't think that you're coming to see us and we're going to say IVF right away. It's not true. Sometimes it is true, but not always. So pre-implantation genetics. Dr. Braybeck was talking a little bit about this. And this is where, if you're doing IVF, that in vitro fertilization, where we take some of a biopsy of the embryo and test it to make sure everything's normal. You may need this if you know that you have a genetic disorder in your family. Let's say your husband has cystic fibrosis and you're a carrier. You don't want your children to have cystic fibrosis. This is how we prevent that. Or, like we were talking about with Dr. Braybeck, maybe you want to screen the embryos to make sure your baby doesn't have Down syndrome, or some other thing that may end up even in a miscarriage or not causing the embryo to implant. We can do all that testing, and it's very common in our clinic for people to do that. So those are all things just so that you know, and our embryologist wanted to share with you to let us know that those are some technologies that are new that we are doing. So what impact does infertility have on psychological well-being? You guys can probably answer this better than I can, but it's often one of the most distressing life events that a couple's ever been through together. There's feelings of loss, there's multiple medical decisions that have to be made, there's a lot of uncertainty. You know these treatments aren't 100%, and it can create a lot of emotional upheaval. We're very much here to support you during that journey. We have 2 trained clinical psychologists. We have mind-body therapy at our clinic. So we really, as I said, try to support you as a couple and as a team, and not just medically, in all aspects of your life with infertility. That's very important to us. Some people do have anxiety or depression or feeling out of control, and we can help treat that as well. So we want to know that we're here for you on all different levels. So how does, I get these are just common questions that I thought I'd answer. How does stress impact my chance of getting pregnant? And stress is very controversial. You know, we know some people don't ovulate if they're very stressed, and that's been seen. A high percentage of fertility is unexplained, so is stress contributing to that? Some of these answers we just don't know. Abnormal stress tests have been linked to lower fertility in some studies, but it's not absolute and it's hard to measure. But we do believe that stress reduction improves fertility, so we're very supportive of that. Acupuncture may increase pregnancy rates, and that's also been controversial, or it may not. So each time you read a new study, it kind of shows a different thing. But in general, stress reduction techniques, we're very supportive of that. Massages, acupuncture, things you want to do, we're very supportive of. So and these, a lot of times I tell these things and they seem like very common sense, but they can be big impacts on your fertility. So smoking is very harmful for eggs and sperm. Some illicit drugs like cocaine or heroin can also cause problems. You wouldn't think a lot of people are doing that while they're trying to get pregnant, but sometimes. Limiting alcohol and caffeine, we usually say 1 small Starbucks a day, just the 200 milligrams. Maintaining a healthy weight, and especially at our clinic, we're very supportive. If you're not at that healthy weight and you need some help there too, we'll help you get to that healthy weight too. We're here to support pregnancy and fertility in every way. We want you to take vitamins, antioxidants for men. There was a new study that came out that showed that taking folic acid and vitamin E for men may increase your live birth rate. So that simple thing can help. Folic acid for women helps prevent birth defects. So we are pro-vitamin at our clinic. And get vaccinated. We'll check you and make sure your vaccines are up to date. The last thing we want is for you to get chickenpox during pregnancy and find out that, you know, when you had it when you were 5, it didn't fully cover you. We want you to have a healthy pregnancy, so that's our goal. So we talked a little bit about this, and I'm not going to dwell on it, but it does lower your egg count and it decreases your chances of IVF if you smoke. So we can help you stop smoking if that's an issue. Marijuana, it reduces the sperm number and it decreases the testosterone and increases premature delivery. So we recommend stopping marijuana for at least 3 months. Alcohol, we recommend limiting it. There's no exact number of how much you should be drinking. The safest would be not to drink at all while you're doing fertility treatments. But if you're drinking more than those above numbers, that it decreases the embryo quality, and you can also have a risk of fetal alcohol syndrome. We talked a little bit about this, the 1 small Starbucks a day. This is hard for a lot of people. We definitely don't say you have to stop caffeine altogether. I know I probably couldn't do that either. But if you have very high number of caffeine, then we look at like maybe 5, 6 glasses a day, that did lower birth rates with IVF. Medications and herbal supplements. I mean, this is a huge field. The Fertile Blend, and you know, every day I talk to patients and learn about new fertility treatments that are out there that are over the counter. So just check with your provider. We can look those medications up that you're taking and see if they're safe and healthy, and if there's any studies that even show it's going to help. Because those can get expensive, so we want to make sure it's not going to interact with your fertility treatment, and we can help you there. Also tell us if you're on other medications for high blood pressure, depression, stomach ulcers, hair loss. Some of these may contribute to infertility, so we want to know and make sure that you're off of them. And this is definitely, so Dr. Nanji is our reproductive urologist, do not use testosterone. And that's a very firm message from him, is that if you're applying androgel or taking exogenous testosterones, even if your doctor said that it's trying to boost your testosterone count, it will not. I mean, it may boost your testosterone, but it will lower your sperm count. So sometimes we have to get people off of testosterone, which I know can be a painful process, but testosterone does not help you get pregnant. We do recommend genetic screening. We want you to have a healthy baby. It's very important to us. So anyone trying to get pregnant needs to go through this screening. It's offered to all women. Cystic fibrosis is the #1 thing we worry about for Caucasian couples, because 1 out of 30 people, even if it doesn't run in your family, are a carrier for cystic fibrosis. So if you and your husband both are, then we don't want you to have a baby with cystic fibrosis. So we want to screen ahead of time and make sure everything's healthy and good to go. That's really it. Any questions that you guys have for me?
A lot of people have been talking to me about essential oils, that there are some essential oils that help with infertility. Have you researched anything about that, or?
I don't know of any research studies that show that essential oils improve fertility, but I also can't imagine, like, unless you're eating the oils or doing something different with it, that they're going to hurt anything. So things like that. And I've also even heard of some of my patients using like fertility charms and things like that. I can't see how that's going to hurt your success in any way. So if it's something you enjoy, especially if you find it to relieve stress, or you know, it's nice when you massage it in, we definitely would recommend those things. Any other questions? Yeah.
I'm surprised that IVF is less than 5%. Is that because of the cost, or is it success rate?
So generally, success rate out of all of our fertility treatments is the highest with IVF. The problem is in America there aren't a lot of states that cover IVF, and so sometimes cost is a factor. Also, a lot of times we just get people pregnant without having to do IVF. If you can get pregnant with losing weight alone, or getting your thyroid under control, or a lot of other medical things, or with doing Clomid or Femara, some of those less intense things, we'd much rather do that. Our goal is not to put everyone through IVF.
Did they talk about in the session before just what the success rate was? What do you happen to know what that is?
So you're talking about nationally what success rates are. So a really good website to look at, there's two. One is called SART, SART.org, and another is CDC.gov. Both of those show success rates for IVF by clinic and also the national average. So once you start talking about success rates for IVF, it's very individualized. It depends on the woman's age, it depends on your diagnosis, so we can't give you just this is our success rate, but those websites really break it down well. The only thing to remember about those websites is they're usually about 3 years behind. So if the clinic is doing better and better, then the success rate may be a little different, so talk to your provider and see if it matches. Any other questions?
What percentage is, the cause of infertility is undetermined?
So about 25 to 30%. And that can be a very frustrating area to be in. Sometimes it's nice to know, gosh, if we just got rid of this fibroid, or if we just, could get the sperm count up. Sometimes that's nice to have a cause to be able to work on. But we don't have perfect science in this area, and we don't have all the research studies to answer everyone's, exact cause for infertility. But the good news is there are lots of studies for people who have unexplained infertility, what treatments work. So we have good plans, but not good reasons.
So is there some information that these patients can go, that specialize in the ones that are undetermined?
Yes, I would say any of your reproductive endocrinology clinics are very specialized in unexplained infertility. So yeah, seeing one of us, we definitely can get you on the right path. Any other questions? Okay. Oh, yeah, go ahead.
Someone with extremely irregular cycles,
Yeah.
do you have to regulate everything before you start the process, or do you start the process, I guess, before you get regulated?
We can help you get things regulated.
Okay.
So if your cycle, if you have irregular cycles, you fall into that special category of don't wait a year. We know that you're not releasing eggs every month, so just come see us sooner. And then we can get a really individualized plan to get things going for you. So you don't need to work on that regulation process on your own. If everyone had completely regular cycles seeing me, then I wouldn't be doing what I'm doing, and I love doing what I'm doing. Any other questions? Okay, thank you so much.